I'd like to introduce Dr. Jonathan Barr. He's an EMS fellow, Division of EMS Disaster and Transport Medicine at Cooper University Hospital, which is located in Camden, New Jersey. We're very happy to have him here. He started his career early on, spending 10 years in his local ambulance corps of Fair Lawn, New Jersey. Dr. Barr attended Cornell University, where he also served as Cornell's Chief of EMS Operations. He has his BS degree with distinction in human biology, health and society, and he attended Cornell Medical School, earning his degree with honors in research for his work on topical combat hemostatics. He completed his residence training at the Hospital of the University of Pennsylvania, where he served as chief resident. And as I mentioned, currently he is an EMS fellow at Cooper University Hospital in Camden, New Jersey. So welcome, Dr. Barr.
Thank you, Jamie. I appreciate that kind introduction. I missed the weather out in San Diego. We were just there for the NAMESP conference. So thank you guys for having me. I know medical decision-making capacity is not the sexiest topic like this super EMT over here, but it is an important one. And if we're not well-versed in it, you'll end up meeting, instead of super EMT, super lawyer. And so hopefully we can go over some of the key points of it today. And from what I understand, there are a mix of physicians, base station nurses, and EMS personnel in the audience. So hopefully there'll be something in here for everyone. So as you alluded to, I started out on the local ambulance corps as an EMT when I was 16 here. I also have a lot of involvement in wilderness activities. This was a wilderness medicine class I was teaching. And so I've been operating in the austere environment for a little while now. And now I'm involved in this austere environment out in Camden. And let me show you a little bit about where we're coming from here in New Jersey. So Camden, most of you probably know it because it regularly tops the top 10 list of most dangerous cities in America. It's held the #1 spot for a little while, but things have changed. There's been a lot of police reform here, and we've, as a university hospital, we've been running the EMS here now for the past couple of years. And so it's a city of about 80,000 people and about 40,000 plus EMS calls. It's right on the border of Philadelphia here. In New Jersey. Just to give you a sense of the New Jersey system, it's a tiered system. There's BLS and there's ALS. And ALS typically calls online medical direction fairly frequently, and often we'll get into discussions of decision-making capacity with them via the phone. We also, at Cooper, respond as EMS physicians in the field. So in the photo on the left, you can see one of our fly cars there at this particular scene. So we'll go do some direct field response. We'll do some direct on-scene medical control, as well as in addition to the over-the-phone stuff. And to give you a sense of the environment we're operating in here, you can see lots of areas with debris, makeshift encampments. There's lots of heroin needles around, and opiate use disorder is pervasive here. In fact, our EMS agency is one of the few that will do field initiation of Suboxone, which we're very proud of. And we have a variety of environments in the urban area, from abandoned buildings to the waterfront. And we have the river as well as the BB&T Center, and that's the Battleship New Jersey there. And you can see the view of Philadelphia from Camden here. So again, like I said, about 40,000 or so EMS calls. We have BLS and ALS units under our medical direction. And very frequently we encounter individuals with impaired capacity. And so we'll get into that now. So just a few disclosures. I don't have any financial conflicts of interest with this. I do also want to preface this by saying I'm a physician, I'm not a lawyer. And while there are some legal aspects of this, don't consider anything I tell you legal advice, but it's for your education only. There's also some considerable state-to-state variability, and I recommend you check out your local laws on this. I tried to distill this to generalized principles that everyone can kind of look into and can get something from, but be aware that there's some state-to-state variation in this. And because there's relatively little information out there that we're aware of regarding EMS providers' ability to assess capacity, I actually am just going to start my own research project on it. And so we've been working on a very small unfunded research project, don't have any grants or anything for it, evaluating EMS providers' ability to assess decision-making capacity. And since that's all unpublished, I'm not going to be talking about any of that today. So shouldn't be any conflicts there. Now, this I feel like is the crux of what we're talking about today and the situation we often find ourselves in. how many of us have found ourselves with a patient, maybe they're older, have a little bit of dementia or some degree of dementia, who we think needs to go to the hospital, and they're saying they don't want to go. And so we find ourselves in some form of this situation. I don't know about you guys, we don't carry mace and nightsticks to make our patients go, but we do try to train our folks to be good at assessing capacity. And so hopefully at the end of today, we'll have a better sense of what you can be armed with in assessing your patient's capacity and what some of your options are to help you out the next time you find yourself in this situation. So I'm going to start with why these assessments matter. We'll try to talk about some of the definitions or at least describe medical decision capacity, review how you might approach assessing it. And then I have some case at the end that hopefully we can either talk through or at least have a chat conversation about. And I'd love to hear some of the situations you guys have encountered to troubleshoot them as well. So why does this matter? As early as 1891, the US Supreme Court ruled that patients can't be forced to submit to a physical exam. This sort of helped establish the principle of bodily integrity in common law, and numerous common law cases have held that in the future since that time. It's also later been studied by legal scholars to be considered a constitutional right, and so patients have a right to what happens to their body and bodily integrity. They also have right to autonomy and other rights as well, in addition to the ethical principles that guide us as medical providers, such as trying to respect autonomy, do the right thing for the patient, and of course, to do no harm. So this matters because patients have rights to decide what medical care they want. And as healthcare providers, it's our job to help kind of protect those rights and make sure we honor them. On the flip side, if we violate their rights intentionally or unintentionally, bad things can happen to us. So if you are an EMS provider in the field and you're seeing a patient and you take someone against their will and they had the capacity to refuse and you took them anyway, you run the risk of charges of assault, battery, wrongful imprisonment. And on the opposite end of the spectrum, if you leave someone behind or allow them to refuse and they didn't have capacity, you potentially run the risk of negligence or abandonment issues. And so it's important to get this right in terms of accurately determining a patient's ability to have capacity. Now, don't think it can't happen to you. This is just a quick selection of some of the lawsuits that have involved paramedics, firefighters, EMS personnel, and it doesn't usually happen to supervisory or base physicians, but it has happened that have involved some issue of capacity where either a patient was taken against their will or the patient was not taken and they thought they should have been taken. It's beyond the scope of this talk and my expertise to go through all the legal nitty-gritty details of each of these cases specifically. I will say, as an aside, one thing I took away from reading through some of these, especially in the last one of Wiedemann versus DeKalb County, is be nice to your patients. A lot of times they mention things, sarcastic comments or jokes made by EMS providers, and it looks bad in court, even if everything else was done well. So something as an aside from that to keep in mind, but just be aware that litigation happens under these circumstances, and refusals are actually the most commonly litigated call type in EMS, and those often involve capacity decisions. So it's important for us medical legally. And if you end up in court, you can end up with fines, maybe even jail time, depending on what happened and what your state rules are. So it's really important that we get this right. Now, some of you might be wondering, well, are we any good at this? Are EMS providers very good at assessing medical decision-making capacity? And while I would say the literature is fairly sparse on this, which is why I'm doing more research on it myself, there is some evidence that suggests that patients who are seen by EMS and do not go to the hospital frequently bounce back. As high in some cases, 48%, somewhere between 30 and 40% of these patients may be bouncing back to the healthcare system in some way, shape, or form. So it seems like there's room for improvement there if we have a lot of these bounce backs. Not only that, you might be wondering, well, are physicians any better? And at least one review of physicians showed that physicians frequently make mistakes on this as well. In one case, there was up to 40% of cases where patients failed to recognize, where physicians failed to recognize incapacity in their patients. So we're usually pretty good at determining who definitely doesn't have incapacity, But there are other patients that the physicians thought had capacity who were independently assessed to not have capacity, and those got missed. So physicians are making mistakes on this too. And I think that reflects some of the challenges involved in making capacity assessments. So if I sum up why this matters, it matters because patients have rights and we have to try to protect them. There's also consequences for us medical legally, which I know is on the front of our minds. And these types of calls, the refusals, are often highly litigated. And then lastly, EMS providers and docs so far in the limited literature available show that we have some room to improve on how well we do these assessments. Take all those three things together, and that puts us in the danger zone for medical decision-making capacity assessments. So I've been using the term medical decision-making capacity. I know a lot of you have probably heard this term in one way, shape, or form through your daily work in the EMS world. But what exactly is it that we're talking about? And so I wanted to mention a couple of different terms here to help kind of clarify this. So first, I'll start with competence at the top of the pyramid. So competence is a legal determination. A court can deem someone competent or incompetent. And in the setting of EMS on a scene, it really isn't practical to be calling a judge and getting a determination of competence of the patient to be able to make decisions for themselves. Sometimes it may be known ahead of time if the patient's not legally competent. You say, well, okay, a minor is not going to have legal competence in a lot of these cases, but this is a legal determination and EMS has to make a presumptive determination of this. So we're going to come back down to the next layer here, which is consent. And I'll specify this as informed consent. And the flip side of this, and the same principles apply to informed refusal. Usually this becomes more of an issue on refusals compared to other situations. To have informed consent or informed refusal, you need to have capacity, and then you need the additional ability to be free from coercion and to fully understand the risks and benefits of the information presented to you after you've been presented it. So consent is kind of based, and also informed refusal is based on the final pillar of having capacity. If you don't have decision-making capacity, you can't consent and you can't be competent. So capacity is kind of the foundation of this pyramid when you're trying to make an assessment of the patient's ability to make decisions. So what is decision-making capacity? Now, depending on the references you look at, there are different exact definitions. I'm going to pull one from the SEMSO here to share with you guys. So that's the National Association of State EMS Officials, for those who may not be familiar, and they've created a national model clinical practice guideline. And in it, they list this definition of decision-making capacity. So they define it as an individual who is alert and oriented. So that's the first part, establishing orientation, has the ability to understand the circumstances surrounding illness or impairment, as well as the possible risks of refusing treatment and or transport, is typically considered to have capacity. So that's kind of the basic part one of this definition. It gets at the orientation criterion and then the risks, understanding risks and benefits criterion. Part two of it discusses sort of disqualifiers, saying that the patient can't be impaired by their illness, such as a head injury, for example. They can't be impaired by drugs or alcohol, or individuals who have attempted suicide, verbalized suicidal intent, or other things that suspect suicidal intent should not be regarded as having decision-making capacity and cannot decline. So this is part of the NASEMSO clinical guidelines. I think what is in here is good, but there's probably a few more things to be aware of that if you look at other definitions and other descriptions are kind of in there. So one thing is the patient has to be given and understand the relevant information about the proposed tests and treatments. They allude to that in the NASEMSO definition, but it's really important that the patient gets good information about what they're talking about. And diagnostic tests here, sometimes I talk to EMTs and stuff, they're like, well, I don't do lab tests, but this also includes vital signs, putting the patient on a monitor, pulse oximeter, even a physical exam for diagnosis can be kind of thought of in the same way, as well as treatments that they administer. The second middle box, the patient has to appreciate their situation, I think is sometimes a little more difficult to understand. What this is getting at is if you come up to a patient with chest pain and you do an EKG in the field and you say they're having a STEMI and they say, no, I think I'm just having GERD, they're not fully appreciating what you're telling them and necessarily understanding the gravity if that's what they're deciding. And that requires more discussion with them so they can understand the decision. The patient also has to be able to use reason to make a decision. They have to give you a reason. So in a lot of places, if you say, oh, I don't want to go to the hospital because the sky is blue, that's not good enough. Whereas you might have to say, I don't want to go to the hospital because I'm on hospice and I'm going to see my hospice nurse tomorrow. There's a logical reason, and you can follow the logic of the patient. The other thing that's important is that the provider doesn't have to agree with the reason. The patient might say, well, I don't want to go because I need to stay home and take care of my dog, and I understand this is bad for me. But you can follow the patient's reasoning, and even if you don't agree with it, that's okay. But they do need to demonstrate that they can make a reasoned choice. They also have to communicate that choice. That sounds obvious, but I've at least had one medic command call report to me where the patient just wouldn't say anything or would stonewall or wouldn't communicate what their choice was in any way. And that's hard to know their decision if they haven't communicated the choice. And then the last thing is there are a couple of other disqualifiers that weren't explicitly mentioned in that NSEMSO definition I presented to you. One is that the patient can't be a minor, or if they're a minor, they have to be an emancipated minor, and emancipation rules vary a little bit by state. But in general, you could think of this as people who are enrolled in the military, or in many states, pregnant patients, such as a pregnant teenager, will have medical decision-making capacity in at least related to their pregnancy decisions and or all their decisions, but it varies a little bit depending on where you are. The other thing that was also not mentioned, we mentioned suicidal ideation, but homicidal ideation can also be a disqualifier here. So if you add these general principles with what NSEMSO laid out, I think you have a pretty good sense of what's involved in medical decision-making capacity. And so then let's get into kind of the practical determinations. When I talk with our EMTs and paramedics a lot, some of the things I'll hear are something like this. They'll say, Doc, he's answering all the questions. He told me his name. He told me where he is. He told me how many quarters are in a dollar. What do you mean he doesn't have capacity? I'm not going to kidnap him. They often will say that, and that's a frustrating word because it makes it sound like you're doing a bad thing or being a bad guy, but we're not kidnapping anybody. We're doing the capacity assessment. And what I think this gets at is the common misconception that orientation does not equal capacity. So just because you can say your name and the date and where you are and how many quarters in a dollar is not enough to say that you have decision-making capacity. It also involves all the things that we just mentioned: risk benefits, using reason to make a choice, communicating a choice, appreciating the situation. So orientation alone isn't sufficient. And so be aware of that, especially I find a lot of EMS providers get confused about that, and sometimes hospital personnel too. The second thing to recognize, and this is also particularly challenging, is that capacity lies on a spectrum. So someone can have full capacity. They can make all their medical decisions for themselves. Then there's the opposite end of the spectrum, is the patient who clearly has no capacity at all, such as in acute psychosis. They can't make any decisions for themselves. And then the more challenging area is in between, where you have patients who may have a limited capacity, meaning that they can make certain decisions, but not others. To give you an example of a situation that might involve is, for example, consider an elderly patient who has some degree of dementia. They may have enough ability to appreciate the situation and understand the risks and benefits of a low risk decision, but they might not have enough to understand the risks and benefits of a high risk decision like surgery or something like that that's more invasive. So that is very difficult, especially for EMS providers, and often requires physician assistants to help sort that out. And it depends on a case-by-case basis, but there are patients who will have a limited capacity where they can make certain decisions for themselves, but not others. Now, the other thing that sometimes confuses people is capacity varies over time. So you may at one point be incapacitated. Imagine someone who's been having too much to drink. They've been in the ER all night, and they don't have capacity when they first come in, but by the morning, they may have sobered up, and now they could have capacity at that point. So once someone is deemed, quote unquote, incapacitated, that doesn't mean they're always incapacitated. They have the possibility to regain that. Similarly, if they have a critical illness, they could recover from that and have regained capacity at a later point. And capacity can also be optimized. And so this is a common situation we'll run into in Camden, is we'll have an opiate overdose. The patient will get administered Narcan. They'll wake up, and someone who was originally, somnolent with respiratory depression, didn't have a great mental status, now wakes up fairly quickly and regains a lot of their mental status. And so they may then at that point recover some of their capacity, or at least optimize it. And the same is true for the hypoglycemic patient. You may be able to optimize the patient if they have a rapidly reversible etiology of why they didn't have capacity in the first place. And so if you take all that together, this is a little algorithm I wrote together that I've shared with our EMTs and paramedics to try to give them a stepwise way that they could go about looking to try to decide if their patient has decision-making capacity. So first, check for anything that disqualifies them right away. I think that's the easiest branch point. If they have one of these things, you kind of know they don't have capacity. So if they're a minor and they're not emancipated, no go. If they're clinically intoxicated, and that's the really important thing, they have to be clinically intoxicated. Having 1B, or if you're not clinically intoxicated, doesn't automatically disqualify you. SI and HI, they don't have capacity. And if they won't communicate a choice, or they can't communicate with you in some way, then you're not going to be able to determine they have capacity. And so that's kind of your first branch point. At that point, you can progress down and explain the risks and benefits. And I'll show some language of what I'm talking about by explaining the risks and benefits, because they really have to be explain the risks and benefits. Check for understanding of those risks and benefits. Again, that's getting at the appreciation of the situation. Did the patient appreciate the situation? And if they can't demonstrate that they understand that, then they don't have capacity at that point. Lastly, what's the patient's reason? Figure out the reasoning. Do they have like a logical progression of events? They understand why they're making a choice. You can understand why they made the choice, even if you don't agree with why they're making the choice. And then lastly, this isn't part of the capacity assessment, but in anyone who they determine has capacity and wants to refuse, I recommend at least give them some callback precautions. Tell them they can always call back EMS. Tell them that we even have them often say that EMS isn't angry with you. We'll still come back to future emergencies. We're not saying that we are upset with you for not going to the hospital against our recommendation, even if we do. And then say, hey, go to a different ER, go to a doctor's office, go get seen in some other way, encourage them to seek care in some other way, as well as giving the return precautions as able to look for warning signs, symptoms, or other things to watch out for. So I alluded to this before about really explaining the risks and benefits. And I've seen too many times on charts and in person when I've responded to scenes, EMTs when they're, or paramedics sometimes when they're evaluating a patient, they'll say, oh, yeah, if you don't go to the hospital with us, you're going to die, or you could die. If you refuse, you could die. And that's really not sufficient to really explain all the risks and benefits and allow the patient to make an informed choice. So we could take a look at this example of, let's say you had a person who fell while they're on blood thinners. You can't just say, oh, you fell on blood thinners. If you refuse to the hospital, you're going to die. Instead, you would say like, hey, you hit your head. You're on a medication that increased your risk of bleeding. We're worried. We're concerned about you. That's helping express the gravity of the situation, that you have bleeding around your brain. And we can't tell you that without a CT scan, or we can't tell you that without taking you to the hospital. Even if you don't know the test, you can say, we can't tell you that without having a doctor look at you and take you to the hospital. We think a doctor should evaluate you. If you don't go to the hospital, the bleeding could get worse and could result in disability or death. Do you understand? Can you repeat back? So it's more than just the, hey, if you don't do this, you could die. So, and then we try to stress that with them. We even wrote sample language into our protocols that they can copy and use almost as a script. If they don't know exactly what to say, they can refer to that. So before I kind of get forward, we're about kind of midway through the hour, 2:25. I do have a number of cases that I'm happy to talk through. I'm also happy if you guys have some cases that you want to go through. I'm happy to kind of troubleshoot some of these. A lot of these are challenging and sometimes there are no good answers. So I want to just open it up, Jamie. I don't know if there are any questions. People can throw them in the chat, or if they have any cases they want to run through. Otherwise, I have a bunch of cases that we could try to talk through. The capacity assessment. And then I think also the interesting thing for EMS as well, even if you determine they didn't have capacity, what are you going to do about it? Because oftentimes there's not a great choice about what to do, even if you decide they don't have capacity.